Greetings to all, we are presenting a video of repeat deep anterior lamellar keratoplasty for failed primary doc. The authors are Dr. Ritu Arora, Dr. Monica Lohchab, Dr. Pallavi Dokania, Dr. Neha Sandhu, Dr. Shipra Sharda, affiliated to Cornea and Refractive Services of Guru Nanak Eye Center, New Delhi, India. We declare that with respect to the following presentation, there has been no relevant financial relationship between the party listed above and any for-profit company, which could be considered a conflict of interest. We had a series of failed grafts following DALK done, for varied indications, over a follow-up ranging from 4 months to 14 years. The causes being interface opacification due to haze, deposits or vascularization, infection, macular dystrophy with endothelial involvement, type 2 bubble or pseudo-anterior chamber formation, graft melt and recurrence of primary disease. Compared to pent-rating keratoplasty, DOC has a better long-term graft survival, better endothelial cell counts and minimal or no risk of post-operative complications like graft rejection, glaucoma, complicated cataract, constant endothelial cell loss, expulsive hemorrhage, and endophthalmitis. However, the visual outcomes and graft survival following DOC are variably reported to be similar to penetrating keratoplasty. Considering the advantages of DOC over PK, we decided to perform repeat DALK in all the failed grafts, with normal endothelium. Repeat DOC can be done by lenticule separation from the bed in layer by layer manner or with the big bubble technique. We could make a big bubble successfully in this case, where the graft failed due to interface opacification and vascularization. First center of the cornea, and 16 radial lines for 16 interrupted sutures are marked using gentian violet paint and an RK marker. Partial thickness trephination is done up to 2/3 of corneal thickness using a disposable trephine blade. A suction trephine can also be used. A lamellar dissection is carried out using a crescent blade and the anterior stroma is removed, leaving a thin residual stromal bed. Anterior chamber is decompressed by making a self-sealing paracentesis. Following this, a 30 gauze needle is advanced in the residual stroma and then air is injected in the stroma to form a big bubble. Notice the big bubble formation. Mark is made in the host bed for making a small incision. Viscoelastic is then injected through this entry in the potential space to clearly separate the overlying stroma from decimet membrane. Notice the further expansion of this space. The residual posterior stroma is then divided into 4 quadrants with a pair of blunt-tipped Vanus scissors which are then excised. A 0.25 mm oversized donor graft devoid of endothelium is sutured in place with 16 interrupted 10-0 monofilament nylon sutures. The graft was clear and well apposed in the post-operative follow-ups. The patient achieved a BCVA of 612 by 6th week of follow-up. Here we performed redoc by layer removal of primary lenticule and retained opaque stroma from the primary surgery, which itself was also done by layer technique for Salzmann nodular degeneration. After the initial steps including marking the cornea, partial thickness trephination and anterior stromal debulking is done. And then a 30 gauge needle is inserted horizontally in the residual stroma, but a big bubble could not be made. So the residual posterior stroma is dissected in layer by layer manner using crescent blade. Donor tissue free of endothelium is then sutured in place. Fared well on follow-up and achieved a best corrected visual acuity of 618 by 6th week of follow-up. We had a case of interface infection following a doc. There are various such reports of interface infection. Due to poor response to medical treatment, rapid progression and high incidence of involvement of Decimetes membranera, almost all of the reported literature recommends an early penetrating keratoplasty as surgery of choice. Fortunately here the infiltrates resolved with medical management alone, leaving behind a vascularized opacity causing graft failure. We attempted a possibly challenging redoc in this case despite the fact that primary surgery itself was for keratoconus with hydrops. After the usual initial steps till partial thickness trephination, a layer by layer dissection is done gently. Bare-scarred Decimetes bed is now visible. Endothelium stained with trypan blue is removed from the donor tissue, which is then trephined and sutured over the host bed with 10-0 interrupted monofilament nylon. Graft is clear, well attached, and there was no episode of rejection. The patient achieved a BCVA of 636 by 6 weeks. In conclusion, redoc is an excellent alternative to penetrating keratoplasty for failed primary doc with normal endothelium. The technique for repeat doc is simple and similar to primary docs.